Bismillah. Assalamu alaikum, doctors. Can you hear my voice? If you can hear my voice, just please write on the chat box. Okay. Bismillahirrahmanirrahim. We are just collecting our colleagues. Okay. So, doctor, this will be a history station, station 2. So if any of our dear colleagues want to start the case, he or she is welcomed. Give me a few moments, I am preparing it. Okay, doctor. Anyone wants to take this case? It's history station. Just please raise your hand or send a message. Yes, Dr. Samir. Okay, you are unmuted now, Dr. Samir. You can hear my voice, Dr. Samir?
Oh, I can hear your voice.
You can hear my voice?
Yeah, I can hear your voice.
Okay, so you are having 5 minutes just to prepare your things, your stuff. Okay.
Okay.
Yes, Dr. Samir, you are unmuted. Take your time. Dr. Samir, can you hear me? Are you ready?
Please give me 1 minute.
Okay, okay.
Yeah, I can start it now.
Okay, Dr. Samir, go on.
Hello. Good morning, Mr. Good morning.
Good morning.
This is Dr. Samir, one of the doctors here.
Welcome.
Is this Mr. Jack Robinson?
Yes, doctor, that's him.
Are you 55 years of age?
Yeah.
Hey, nice meeting you, Mr. Robinson.
Thank you.
Mr. Jack, actually, we have received a letter from your GP that you're having some weakness. May I know more about it? While asking you history, I might write some notes, but that will be highly confidential and my full attention will be with you. Is that fine with you?
It's okay, doctor.
Please tell me more about your complaint. What
Okay.
do you mean by weakness?
Weakness, doctor, you know, for the last 4 months, I started to have weakness in my hands and in my legs. You know, usually I walk every day for about 1 kilometer, going and coming to my work. But recently, for the last few months, I cannot, you know, I cannot carry objects. I cannot go to my work easily. You know, I have to have some rest. I don't know what's going wrong with me.
I'm really sorry for that. Let me see what's going on, and we'll try to settle the problem. Tell me, Mr. Jack Robinson, may I know how did it start? Did it start suddenly or it started slowly?
I cannot remember, but you know, it's for the last few months actually. But it didn't start suddenly, for sure.
Okay. When is the weakness more in your legs and arms? Is it more in the morning or it is more in the evening?
No, it's all over my muscles, my upper limb and my lower limb.
Mm-hmm. Are you able to walk nicely?
No, doctor, I cannot walk good as before.
Mm-hmm. Is there any difficulty in climbing upstairs?
Climbing upstairs, sometimes, yes, sometimes.
And any difficulty in combing your hair?
Sometimes, yes. I found problem combing my hair, yes, also.
Okay. Do you feel the muscles are stiff or floppy?
My muscle, more floppy, doctor. It's not that stiff.
It's not stiff, okay. Okay, tell me, when you are doing any day-to-day chores or exercise like walking or combing hair, is it increased on doing that work or it gets better after certain exercise?
No, doctor, I cannot do exercises, you know. I cannot do, I'm a lazy person, by the way, sorry. I just go to my work and come back. I don't practice any kind of exercises.
Okay. Any, you don't do any, so it doesn't improve with doing any work like walking or anything?
No.
Has anyone told you that you have turned pale or color is getting
That I have
paler?
what?
Has anyone told you that you are getting pale?
Pale? No, I'm not pale at all.
All right. Tell me, is this weakness, is it associated with, is it increasing with anything? This weakness in the legs and arms?
Weakness in the legs and associated with what?
Is it increasing with anything?
No, no, doctor, I cannot walk well. I cannot do my job well. I'm working at a bookstore. Even now, I cannot even raise box well to the roofs,
Okay. Can you shelve the books up?
I cannot do it well. Yes, I can do, but hardly.
Do you feel that there is any blurring of vision by the end of day?
Blurring of vision by the end of the day? No, doctor.
There is no drooping of the eyelids by the end of day?
No.
Okay. Is there any fever in the recent past?
No, I didn't have any fever.
Any changes in appetite?
No, I eat well.
Okay. Are there any changes in weight, like increase or decrease? Do you feel change in your outfit size?
No, I didn't look like this.
Any history of cough?
Cough? No, doctor, I don't have cough.
Okay. Any history of contact with any person having TB or tuberculosis or any other infectious problem?
No.
Okay. And tell me, do you have any racing of heart with this weakness?
Racing of heart?
Yeah.
With this weakness? No, I don't feel any weakness of my heart with this weakness.
Not pain also. Gait is normal?
Sorry?
Gait is normal?
Heat? Yes, heat is normal.
Okay. Okay. Tell me about your past history. Is there any past history of diabetes?
No, I don't have any diabetes before.
Any high blood pressure?
No, doctor, I don't have high blood pressure.
Okay. Any past surgical history? Have you undergone any operation in the past?
No.
Any history of allergy to any medicine?
No, I don't have any allergy to any medicine, doctor.
May I know your medication list?
Medications? Yes, doctor. I'm using this medication for my, because, I'm a little bit fatty person. I'm using a medication to lower the cholesterol. My GP told me that I am having high cholesterol. Also, I'm using paracetamol occasionally because I have back pains. And I use a medication, I cannot remember the name well, but my physician told me that's to control my heart rate or something like this.
Okay. Tell me one thing, any over-the-counter medicines besides you are taking?
Just this paracetamol only, sometimes.
I'm sorry to ask you this question, which I have to ask everyone. Please don't take it otherwise. Are you using any acid drugs?
No, doctor.
Okay. Tell me, any family history of note, like diabetes or any other such history in your family?
Yes, my mom and my dad both had diabetes.
Okay. No, any family history of cancers, any cancers running in family?
Cancer? No.
Okay. Tell me, Mr. Jack, when you wake up in the morning, is there any difficulty in getting up from sitting position, like you feel dizziness or anything?
Sometimes, doctor, not usually, sometimes.
Sometimes, okay. Any, the blood pressure is normal? No history of, as you told me, there's no history of high blood pressure.
No, no, it's okay.
I might ask you some personal question. Please don't take it otherwise. What about your intimate relation? Is it fine?
Yes, doctor, it's okay.
I'm sorry, are you in any long-term relationship?
No, doctor, I am married and I am a conservative person.
Okay. But there's no problem in the intimate relations.
No, no, no.
Okay. Okay. I will just ask you a few questions. You can say yes or no with that. It may not be related to your present illness, but then it will help us in coming to the diagnosis. Is that fine?
Okay, doctor.
Okay. Is there any history of chest pain or breathlessness?
Just pain, no. But sometimes, you know, I have some shortness of breath, yes.
Mm-hmm. What do you mean by shortness of breath? Like, how often is it? Is it on walking or it is?
Sometimes when I walk, sometimes it comes even if I'm sitting.
Okay. Do you need extra pillows to lie down while sleeping?
No,
There's no swelling in the legs.
no,
Is there any tummy pains?
no,
Yellowish discoloration of eyes?
no, doctor.
What about your waterworks? Is there any increased frequency or frothy bubbles in the urine?
No, my waterwork is okay.
What about your bowels? Is there, are the bowels normal?
Sometimes I have hard stool, doctor.
Okay. Like, what is your usual routine?
I usually go to my job and go back. That's all. 2 minutes remaining.
Okay. Mr. Jack, let me summarize what I have asked you so that we can see.
2
You
minutes.
are having a Sure. You're having weakness from past 4 months in the hands and legs, and which is really hampering you for performing day-to-day chores. You're not having any past history of diabetes, but you are on medications for your cholesterol and over-the-counter paracetamol. Do you want to add anything else in this?
Anything? No, doctor.
Okay. May I know your concern, please?
Yes, doctor. I want to know what's happening, going wrong with me. I cannot.
Oh,
I'm not. I don't know what's it.
I highly appreciate your concern, Mr. Jack. Actually, I would like to do the complete examination, and then I'll be able to actually see what all is going on. But as per the conversation with you, I can see that the problem of weakness, which has happened from past 4 months, seems to be related to one of the medication which you are taking for reducing cholesterol. Has there been any change in the medication in recently?
Have what?
Dose of the, has there been any change in the medicine for cholesterol recently?
No,
Any
doctor.
increase in the dose?
No,
Okay.
no.
Are you smoking?
Occasionally.
Okay. How many cigarettes?
Occasionally, I don't, maybe 2 times per week, I use 2 or 3 cigarettes only.
And do you drink alcohol?
Never.
Okay. Well, Mr. Jack, it looks like that you're having a problem related to your medication. Else, I'm going to run certain tests, battery of investigations.
Time.
To see.
Thank you. Okay. What's your differential diagnosis, doctor, for this patient?
My differential diagnosis is first drug-induced myopathy, proximal myopathy, which is because patient is on Simbas. No, I don't know what is he on, but he's on the drug for cholesterol, which usually is HMG coenzyme inhibitors, and they have a side effect of myopathy. Patient can also have endocrinopathies, but he doesn't have like hyperthyroidism, but he doesn't have any racing of heart or any other problem. I have ruled out myasthenia gravis by not having the problems after the effort, and he doesn't have any drooping of lids and difficulty. I forgot to ask about swallowing and speaking, which was important. I forgot about that. Myasthenia I have ruled out. Another differentials we can have, another differential which I ruled out was Eaton-Lambert syndrome, but patient doesn't show have any evidence of malignancy of lungs or anywhere else. Patient can also have motor neuron disease, but doesn't look like, because the limbs are floppy and he's able to walk sometime, and then and that is again a differential. A patient may have hypokalemic periodic paralysis as well, but then there is no such family history, which with the history with conversation I can rule out. These are the basic differential diagnosis.
Okay, so you put the first, yes?
Polymyalgia, even polymyalgia rheumatica I have ruled out, but he doesn't give any history of headache or blurring vision or any other problem.
Okay, so you put drug-induced statin as the first of your differential. Do you think that statins can lead to shortness of breath or constipation?
No, statins cannot lead to that. Okay. He doesn't have weight. I was thinking of hypothyroid also, but
okay. So this gentleman, did you ask him about his past history, well, doctor?
Yeah, I asked him. He told that he doesn't have any diabetes, high blood pressure. I asked any past surgical history. He said nothing.
Any hospital admission before?
I didn't ask hospital admission specifically. I asked about the past surgical history.
Okay, so this gentleman told you that he is receiving a medication to control his heart rate. Did you ask him what type of medication he is receiving or why?
No, I didn't ask him that.
Okay, so this patient had floppy weakness. Does he have any sensory affection? Or did you ask him that he is having any sensory affection?
Okay. I asked whether he likes like walking on a cotton wool. I didn't ask that. I forgot.
That's okay. Any change in the color of his skin, for example?
No.
Okay. Thank you, doctor. Good job, Dr. Samir. I'm sorry for being silly, but I'm trying to be as examiners if they are more silly than this. But again, I will repeat it 2,000 times, no problem. Please, doctors, whenever you are going to station 2, and sometimes station 5, you look at the board, please, doctors. You will receive a plain paper outside. This plain paper, you should do it in it like this outside. First, you will divide the paper like this. Sorry. You will divide the paper like this. Here, you will write your differential diagnosis. Here, you will write the analysis, CRP first. Okay, WT. Then here write the positive data. And then here write the ICE plus the management plan. If you did not put the paper in like this or any form that will divide things like this, you will forget. 100% you will forget. We are not machines, okay? We forget everything, and you are keeping mentally blocked. And again, you are traveling from another country to another country. You are preparing yourself for a few months, or maybe 1 year, and then meeting people for the first time. You don't know them. You never saw them before in another climate, and you didn't sleep well last night, and then even you didn't receive eat your breakfast, and then you came. You think that you will remember everything. For sure, you will miss something inside. So please, doctor, don't worry to write these things and even to look at this paper inside, okay? And then start doing like this. Outside the station, you will write your differential diagnosis here. So this part will be filled outside before entering the station, okay? So we will leave it for the next slide after this one. Here, you will start analyzing the things. You will start by analyzing C, which is C for complain. And please, doctor, after finishing everyone from this is a checklist, doctor, okay? After finishing everyone, put a tick in front of it. And look at it. Put a tick inside the exam, don't worry. The examiner will not tell you what are you doing. Don't worry about this at all. Okay, so write C, analysis of the complaint, onset, course, duration, what increase, what decrease, association, effect of treatment, and date of last attack. Plus, do you have any other symptoms? Okay, so doctor, go in this way. Can you please tell me when did this weakness happen? This is the onset. He will tell you for the last 6 months. Is it acute or no? No, doctor, it's not acute. This is the onset, course, and duration. Did you notice that there is anything increase it? No, doctor. Anything decrease it? No. Or sometimes when I sit down, everything is okay. Is it associated with anything? No, doctor. It's not associated with anything. And if he may ask you like what? Tell him like chest pain, shortness of breath, or depends on the situation you are in, or pins and needles, headache. Okay. Then effective treatment. Did you receive any medication for this problem before? No, doctor, I did not. And date of last attack. When the last time did you feel this weakness? Last night, doctor. Okay. Do you have any other symptoms? Here comes the point, doctor. If you asked me from the beginning, do you have any other symptoms after analyzing this one? Do you have any other symptom? Or do you have any other problem? Do you want to add to this? He will tell you, yes, doctor, I'm having some shortness of breath. And I'm having also some hard stools. Okay? Or constipation. By the way, constipation is not a jargon. Okay? So you can use hard stool or even constipation. So doctor, please be noted that he will not write all the symptoms to you outside the station. He will write one symptom only or two symptoms, and then you should capture the rest from inside. So onset, course, duration. Can you please tell me more about your condition? He will keep talking. So you remind yourself again. So it started 6 months ago in a gradual onset. You didn't notice that there is anything decrease or increase it, yes? And it's not associated with any other thing, and you didn't receive treatment for it. And last time you felt it yesterday. Yes, Mr. Jack? Yes. Do you have any other symptoms you want, or any other problem you want to add to this? No, or yes. Then come to a review of other systems. You can start by the most prevalent system, especially if you are in station 5, or you can take it from above down, from head down to toe. Okay? the problem, Dr. Samir, when you asked about family history and then some things, and you went back again to the review of other systems. No, you should review the other systems and go back again. And this will be given. You will be given a remark for this, because they will say that the candidate is hesitant. It is not fluent. Okay. So R is a review of other systems, from above down. Head, do you have any pins and needles? Please, this patient is having weakness, so you have to ask about neurology symptoms. Well, do you have any headache, any visual problem? Do you have any other visual problem? Any weakness? Any headache? Any loss of consciousness? You should ask about this. This is very important. Any numbness at any area of your body? No, doctor. Okay. Do you feel that this weakness is floppy or stiff, as you asked? And this was a good part from you, good thing from you. Then go down. What's after this? He told him, there is no visual problem. Okay. Then ask him, do you have any, go to the neck, any thyroid problem, shortness of breath, any thyroid problem, heat or cold intolerance or weather preference, any constipation, okay, any tremors, excessive sweating, racing of your heartbeats? No. Go down to the chest and the heart, any chest pain, shortness of breath, racing of your heartbeats, any cough, any phlegm? No, doctor, nothing. Then go down to the GI symptoms. You should ask rapidly. Do you have any loose motion, any constipation, any tummy pain? No, doctor, nothing. Then you can ask about other symptoms: joints pain, muscle weakness, muscle pain, any skin rash. This is the way that you should go. And after finishing, put a tick. So, okay, now and down here, if you captured any positive data from above here, you should write it here directly. So if he told you the main problem he came with is the weakness, you can write it also from outside in the positive data part. Then what else? Shortness of breath, constipation. You should write these things, doctor, okay? Because you will attribute these things to each other when you are summarizing to the patient, and you will not forget anything. And at the one moment reflection, you can again review your data. For example, if you said something wrong for the patient, you can make the correct again when you are talking to the examiner. Then come to the past history. Here, when you are talking about the past history, we are talking about, I will just remove these things. When you are talking about the past history, doctor, you should ask about past history of chronic diseases. Generally, you should ask him about chronic diseases. You ask it only about diabetes and hypertension. Okay, that's good to ask about diseases by name, but ask him generally, do you have any chronic diseases? Do you receive any medications and the drug list? Okay. Any past history of blood transfusion, hospital admission, any past history of allergy, any past history of operations or procedures. If you ask it these 6 things, he will tell you this. Yes, doctor, I'm having a problem. You told him, do you have any diabetes? He told you no. Do you have any hypertension? He told you no. He answered what you asked. But you should ask him generally, do you have any chronic diseases? Yes, doctor, I'm having a heart problem. I cannot remember what was this. Okay, so what were the symptoms of this heart problem? It was racing of my heartbeats, and my heart physician prescribed me a medication. I cannot remember the name of the medication, but I take it. Okay, then you have to ask about the medication. When the patient tells you that he is taking a medication and you suspect that this medication is related to your case, you should ask him any change, as you did, but you did it at the end, after asking the patient's concern. You should ask any change in the dose of this medication. Did you introduce any new medication to this medication, doctor, the case completely may be drug-drug interaction. And this was the case here, drug-drug interaction, okay? So, yes, I'm receiving a medication. So you can write down here, is receiving anti-arrhythmic medication, okay? And question mark, because I don't know what is this anti-arrhythmic medication. There is any hospital admission before? Yes, doctor, I was admitted because of this, my heart problem. You didn't ask about any hospital admission before. If you asked it, he would have answered you, yes, doctor, I have been admitted due to this heart problem, and they did something called, I cannot remember it, but they told me it's like what, ablation or something like this. Oh, now you got the case. This patient is receiving a medication called amiodarone. For sure, this is a medication usually, they can give beta blockers or whatever, but now you are thinking it may be amiodarone. Then go to the family history. Family history of chronic diseases, of consanguinity if related. Then come to, and here you should write TEC. Family history, TEC. Then allergy, TEC. Then come to the social history. Social history concludes asking about, one second. Concludes asking about in the social history, you should ask about smoking, and you ask it after asking about the concern. Plus smoking index, alcohol, social history, job. And please, doctor, when you are asking about job, the patient is having a job, this is your job all over your life, or you were working in another job before? No, doctor, this is my job. Or yes, doctor, I was working before as a carpenter and now I changed my job. So job includes recent job and any previous jobs. Take care about this. And then hobbies. Hobbies is important. For example, this patient came with weakness. What prevents if he, for example, patient came with weakness. If this patient was, for example, playing football, and he had a trauma at the fibula, and now he is having weakness in his left lower limb, common peroneal nerve paralysis. Okay, so you should ask about hobbies. And then pets, important especially. This patient is having shortness of breath. Shortness of breath may be drug induced, or maybe he is having extrinsic allergic alveolitis because he's having a new pet, for example, parrot or a dog or whatever. Okay, then come to the sexual history. The sexual history, one question, are you married? Yes. Do you feel any problem in the private relationship? No. I'm sorry to ask you this question, but usually we need to ask it to all patients. Do you have any extramarital relationship? No, doctor, I'm okay. Okay, so take care. Then come to the psychological history. Very important, doctor, to ask about the patient about psychological history. Can you please tell me about your mood? If you told you I'm in a good mood, no need to continue and asking about things. If you told you, no, doctor, I am not in a good mood. So at this time, you have to tell him, I'm so sorry for this, but can you please tell me, do you have any bad ideas or bad thoughts about life and death? No, doctor, I'm sorry for this. To asking you this, did you try to hurt yourself before? Yes, doctor. If he said yes, doctor, at this time, this patient is having a depression and you should refer him to the psychologist. Okay? Take care about this before. Don't just, if he had depression, he has depression. No, you should analyze the depression. Is it just mild depression that happens to us as doctors, or this is a severe depression that needs to be seen by a psychiatrist? Okay. Then T, you asked about travel history. So I asked about S and I asked about T. Then the WT is the weight and temperature and temperature. In weight change, in temperature. Come to this patient. Okay. I'll tell you that this case, this patient, the problem that this patient is having is receiving two medications, statins, okay, plus amiodarone. Okay. Statins and amiodarone usually having interaction, because as you know, amiodarone is enzyme inhibitor. Take care, doctor, as regard enzyme inhibitors and enzyme inducers. It can come as a case, by the way. This patient started to have shortness of breath, and it happens with amiodarone. This patient started to have constipation, and it happens with amiodarone. This patient started to have weakness, and it happens with amiodarone. Okay? And this patient was admitted, and they did ablation. So now the patient is receiving a medication, but he doesn't know his name. And when the patient tells you that I don't know the name of the medication, it should raise your suspicion that this is one of the clues that will lead to the issue. When he says, I don't know, I cannot remember, I don't know the name. So it is not a must to be the answer, but it should raise your suspicion about this. Then we will come here to the differential diagnosis of weakness. Okay, I will remove this. Okay, sorry. Before, we have to finish the ICE and management plan. Now, ask him, can you please tell me more what your ideas, and we said before, what the difference between ideas, concern, and expectations. Can you please tell me more about your ideas and the concern? Yes, doctor, I think, I'm afraid, doctor, that I may have, for example, a cancer, because I hear that people with cancer may have some weakness. Any concern? The concern may not be related to the problem, by the way. I'm afraid I may have a cancer. Or I'm afraid that I may have bleeding inside my brain, because I heard before that people who is having a problem in the brain may have this. Or I'm afraid that I may have rheumatoid arthritis, for example. So don't assume that the concern will be related to the condition. It may not be related to the condition, okay? Then you have to answer the patient concern. And please, please don't answer the patient concern by the management plan. Don't tell the patient that I will do CBC for you, and I will do liver functions for you, and based on this, I may do ultrasound to you. No, 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 no. I will do some blood tests for you and some imaging to you, for example, if this is the case, and we'll see. Now, this patient, he is concerned about, for example, cancer. Okay, I appreciate your concern, but usually cancer does not present in this way. Now you answered the patient concern. Don't answer the patient concern by the management plan. The patient's concern the patient wants an answer to his question. This is what's meant by patient's concern. So he is concerned about, for example, rheumatoid arthritis. I have to tell you that this is not the presentation of the rheumatoid arthritis. So this is your answer. Or, for example, if this is your case, I'm sorry to tell you this, but cancer is still a possibility. It's not on the top of my list. It's on the bottom of my list, but it's still a possibility. That's why we need to do some tests to exclude it. Okay? So you should answer the concern, then talk about your management plan after this if you want. Okay? Then, what do you expect from this consultation? I'm expecting you to admit me, for example. Okay? Okay, I will come to answer this now, but I need to tell you that no need for admission, except after doing some tests for you. And for example, patient came with hypercalcemia. Patient came with symptoms of hyperparathyroidism. Tell him that, okay, I will do some tests for you, and based on this tests, I will decide whether you need admission or no. Or for example, patient came with hypopituitarism, some manifestations of hypopituitarism, or hypoadrenalism. You shouldn't discharge him except after making sure that his potassium is not high, because he may die from hyperkalemia. And then come to the plan of management. So, okay, Mr. Jack, I'm suspecting that what's happening to you now is the medication that you are receiving to control your heart rate. This medication called amiodarone? Oh, yes, doctor, it's called amiodarone. Yes, I remember it now. Okay, so I'm suspecting this medication called is the cause of this problem. And here we need to do some tests for you, including tests for your neck gland, and to do some imaging for your chest, and to do some blood tests also for you. Also, I need to refer you back to the heart physician to revise the dose for this medication, or to give you an alternative medication. Also, I need to refer you to the nerve physician as well, and the physiotherapist, to start solving this problem. Do you have any other concern for me? No, doctor, thank you. This is the way. And please, if you found a side effect of a drug in your case, you should ask about other side effects. Okay. Now we will come to the differential diagnosis of, and this is the core of this session, the differential diagnosis of weakness. If your patient came, doctor, this slide very important, extremely important. Please revise this slide that I will write now. Revise it every day. It will come to you in station 2, in station 3, and it can come also in station 5, because neurology cases valid to come in station 5. So if you found a patient with weakness, the first question you should ask it to your patient, as Dr. Samir did, do you feel stiff or floppy? And also, doctor, when you are examining the patient in station 2, you should decide whether your patient is floppy or stiff. Okay? Don't put in your mind upper or lower motor neuron region. Just ask yourself a question. My patient is stiff or floppy? If he is stiff, this is upper motor. If he is floppy, this is lower motor. Okay? So in the exam, ask yourself one question. And this is the first thing, because the first thing after inspection, you will inspect the tone. So inspecting the tone will put you in two differential diagnoses. Either your patient is stiff or floppy. Okay? If he is floppy, so this is a lower motor neuron lesion. Okay? In both situations, the next question should be, is there any sensory affection or no? Is there any sensory affection or no? Here the same. Okay? So we'll come here. This patient came with floppy weakness. Okay, I'm so sorry for this. Can you please tell me more? Did you notice any change in the sensation at any area of your body? Or do you feel that you can, the sensation decreased at any area of your body? Or when you walk, for example, do you feel that you are unstable? Now you are asking about, you are asking about sensory ataxia or posterior column. You are asking about what, you are asking about the manifestations of sensory affection. But in his terms, did you notice that when you close your eyes or when you wash your face with water, do you feel that you are unstable a little bit? He will tell you either yes or no. So if he told you, yes, doctor, I mean there is positive sensory affection, and this is valid also in your station 2. When you are examining your patient and you found he is floppy, you will notice if he is having sensory affection or no. Then if he is having sensory affection, so the differential diagnosis of floppy weakness with sensory affection is the word had S. Had S. Whether the H for hereditary sensory motor neuropathy, Charcot-Marie-Tooth. Sorry, 2 had S, 2 had dash S. And the second H for HIV, and the A for alcohol, and A for amyloidosis, and D for diabetes, and D for drugs. What are the drugs that can cause both sensory and motor? You know the GCI hospitals, there are hospitals GCI accredited, but it will not be J, it will be GCI. GCI man. GCI man. Gold, please doctors write this down. Gold, cytotoxic medications, isoniazid, metronidazole, amiodarone, and nitrofurantoin. Again, gold, cytotoxic, INH, metronidazole, amiodarone, and nitrofurantoin. Then the last S is syndrome. Two syndromes, GBS and Guillain-Barré syndrome, and the other is Coda equina. And you will say what is the difference between Coda equina and the conus medullaris syndrome at the end of this. Okay, if your patient, doctor, came with sensory, with floppy weakness, but no sensory affection, I mean purely motor case, your case is purely motor, just make it smaller. Okay, I mean purely motor case, so you have to think in this way. Is it proximal or distal? If it is proximal, please doctor look at here. Proximal, you know, yes, proximal. If we wrote it like this, proximal, okay? But we will write it piximal, okay? So the mnemonic here, piximal. B for porphyria, please doctor write it down, porphyria, polymyositis, and dermatomyositis. E for endocrinopathies, acromegaly, thyroid problems, hyper or hypo, adrenal problems, hyper like Cushing or hypo like Addison. So again, acromegaly, thyroid, and adrenal. If you found acromegaly, please write down in the chat box, doctor. If you found acromegaly, what will you do? What will you search for also? Acromegaly, what will you search for? 3 letters. Doctors, you can hear me? I'm just asking, you can write. Carpal tunnel, no, oh, association, what's associated also with it? Men, yes, excellent, Dr. Samir. Men, again, men is a very valid case in the exam. Please, doctor, make sure, men type 1, okay? So again, P for porphyrias and polymyositis, E for endocrinopathies. Oh, sorry, I wrote piximal. I should have wrote it like this, piximal, sorry. Okay, then K for potassium, hypo or hyperkalemic periodic paralysis. I for infection, HIV. S sarcoidosis. M myasthenia gravis. Motor neuron disease. And myotonia dystrophy, and this this muscle dystrophies like picker, like shoulder, like limb-girdle type, like fascioscapulohumeral type. Okay. A, alcohol. Alcohol can cause both. Okay. And the last, sorry, alcohol. What else from A? A for anterior horn cell affection. Polio. and syringomyelia. And the last L for Lambert-Eaton syndrome. Sorry, doctors, things are not well tied. Sorry. Okay, doctors. So again, what are the causes? Floppy weakness. Then, do you have any weakness? Yes. You feel this weakness or your body floppy or stiff? It's a floppy. Did you notice that there is any sensory affection, or you cannot, for example, you cannot, you feel that you will fall down if you are walking or if you close your eyes? No, doctor. So you are talking about proximal. Then ask about the cause, this cause. Do you have any liver problem? Do you have, sorry, any tummy pain, any change in any tummy pain? Do you have any change in the color of your urine? No. Do you have any change in your mood? No. You are asking about porphyria. What are the symptoms of porphyria, doctors? Symptoms of porphyria, by the way, porphyrias, abdominal, neuro, uro. Abdominal, neuro, uro. Abdominal, tummy pain, constipation. Neuro, mood changes, weakness sometimes, schizophrenia, insomnia. Uro, change in the color of the urine. Okay? Ask him about, these are called screen questions. So you are asking him about porphyrias, then polymyositis and dermatomyositis. Did you feel any muscle pain? Did you feel any stiffness any hardening? Sorry, in your skin? Any problem swallowing? You are asking about poly and dermatomyositis. Okay, these are called screening questions. Then they ask about acromegaly. Did you notice that there is that the size of the ring and shoes or your hat changed? No. Do you have any visual problem or bumping in objects or problem in the peripheral visual field? He will tell you no. Or in the sides, on the sides of your visual field, he will say no. Then ask him, any weather intolerance, cold or hot? No. Do you have any, do you feel dizzy when you stand up from sitting position? Did you notice any increase in the pigmentation of your skin? No. For example, did you notice there is weight gain? You are asking about Cushing? No. Easy porosis? No. Then ask about hypokalemic periodic paralysis. Did you notice that this problem happens in episodes? I mean, not most of the time? No. Do you have any family history of this? No. Then ask him about infection. Infection, HIV. HIV. Don't forget to ask about HIV, doctor, in all cases, basis. Very important. Very important to ask about HIV. Any extramarital relationships? No. Are you sexually active? Yes. Homo or hetero? Homo. Is it safe sex? You use condoms? No. Any shared needles? No. Any tattooing? No. Any previous blood transfusions? No. Okay. This is the way that you should ask. Sarcoidosis. Any shortness of breath? Any joint pain? Any rash at any area of your body? No. Then ask about the other things. Myasthenia gravis, as the doctor asked. What are the manifestations of myasthenia gravis? Did you notice that there is dropping of your eyelid? No. Do you see the things double, or do you have double vision? No. Do you have any swallowing problem? No. Do you have any speech problem? No. Do you notice that this weakness increases by the end of the day? No. Okay. Then ask about motor neuron disease. The same way. Then ask about this dystrophic myotonia. Same way, but add family history. And then ask about Eaton-Lambert syndrome. You should ask also about what? Smoking history. Very important. Okay. Then, if he told you no, doctor, he will tell you no. I don't have. I am not floppy. I am stiff. Okay. Then here. Okay, doctor, I will remove this slide, doctor, because I have to write in another slide about the weakness, the stiff weakness. So if you want to capture the screen before I am removing it. Okay. Now we will come to the other part of this slide, which is a stiff weakness. Yes, I'm having stiff, but it is, sorry, I'm having weakness, but it is stiff. Oh, sorry. Thank you, Dr. Priya. You remembered me about the distal. Sorry. Good. Thank you. I will remove these things. Okay. So the distal weakness is easy. We said the proximal is biximal, and the distal is mommy N. Mommy N. So what's mommy N? M. Motor neuron disease. A. Anterior horn cell affection. Again, like polio and syringomyelia, as we said in the proximal. Other M. Myotonia dystrophica. I. Inclusion. Body myositis. N for peripheral neuropathy. So the distal is mommy N. Very easy. So weakness, floppy weakness, proximal with sensory affection, 2 head S. No sensory affection, i.e. purely motor, is it proximal or distal? And even you can do you feel how to ask about proximal? Do you feel that you have difficulty in combing your hair, or on climbing the stairs, or standing up from sitting position? This is the questions of the proximal weakness. And the distal is easy. Sorry, do you have any problem in handshaking, for example, or grabbing things with your hand? This is distal weakness. Okay, so proximal, and the other is mommy N. Okay, then we'll come to the stiff weakness. If you are in station 2 or even in station 3, and the first thing you did the tune for your patient and you found your patient stiff, think about upper motor neuron lesion. Now you are in the other arm. Don't forget the proximal mommy N and 2 head S. If he is having stiff, if he is stiff, your patient, then check if it is unilateral stiffness or bilateral stiffness. Doctor, this slide very important, very important. Unilateral, we have 3 causes for this: either hemiplegia, or hemisection of the cord, or something doing pressure in the brain. Okay? Pressure in one side of the brain. Hemiplegia, if you saw a case of hemiplegia, the next step, you should localize. So the most important, this is a very easy case, by the way. If you found a case of hemiplegia, this is very easy, because you will localize the lesion very simply. Then come to the next, hemisection of the spinal cord. If the hemisection of the spinal cord is above C5, it will cause hemiplegia. If it is below C5, it will lead to monoplegia. Okay, so the cutoff point is C5. What are the pressures that can cause this stiff weakness? Either space occupying lesion or an abscess, but unilateral. Okay, this is the unilateral. So if unilateral, hemiplegia, hemisection, or something making pressure in one side of the central nervous system. Come to the bilateral stiffness. If you found stiff weakness bilaterally in the lower limb, what is the name of this syndrome or finding? What is the name? Can you write down in the box, please, doctors? What is the name? Bilateral spastic paraparesis. Yes. Spastic paraparesis. Yes. Excellent, Dr. Asar. Spastic paraparesis. So if you found bilateral stiff weakness, I mean upper motor neuron lesion, now you are talking about paraplegia. It's not a hemiplegia unit. Here you are talking about paraplegia. Paraplegia. When you come to the paraplegia, you should ask yourself one of 2 things. Is there any sensory level or no? If there is sensory level, this is one of 3. Either cord compression, or cord infarction, or transverse myelitis. These are the causes of paraplegia with sensory level. Transverse myelitis. Transverse myelitis, for example, what can cause secondary to sarcoidosis, for example? So here sarcoidosis can cause upper and lower. Okay? So transverse myelitis or autoimmune or infection then come to the things that paraplegia without sensory level. What are the causes of paraplegia with sensory level? Here comes the point. Is there any sensory affection? But here sensory level, but here it is not a sensory level, it's a sensory affection without level. Don't mix between both of them, doctor, please. Sensory level, for example, at the level of the umbilicus, the sensation down is affected, above is not affected. This is called the sensory level. But here, when you find the case of paraplegia without sensory level, but still there is sensory affection, I mean, there is no sensory level here, but the next is there any sensory affection? Yes or no? So if it is no, I mean the case is purely upper motor neuron lesion affection. It's either hereditary spastic paraparesis, which comes in the lower limbs only, or parasagittal meningioma. What's parasagittal meningioma? I will tell you. You know, doctor, these are, if we are looking from front, these are the two cerebral hemispheres, okay? The part between them, it's called the falx cerebri. Falx cerebri, this part, okay? If the meningioma came here, it's called the parasagittal meningioma, okay? It will lead to bilateral lower limb upper motor neuron lesion. I mean, it will lead to bilateral motor spastic paraparesis because it will compress parts of the two cerebral cortex, okay? This is what's meant by parasagittal meningioma. Then, so again, if you found your patient stiff, ask yourself, is it unilateral, bilateral, unilateral hemiplegia, hemisection, or something making pressure? Okay. If it is bilateral, so this is a paraplegia. Paraplegia with sensory level or without sensory level. With sensory level, cord compression, cord infarction, transverse myelitis. If there is no, by the way, doctors, I forget to write here also, paraneoplastic, okay, paraneoplastic. So if it is paraplegia without sensory level, then the next question is there any sensory affection or no? And now we know the difference between sensory level and sensory affection. Is there any sensory affection? No sensory affection, hereditary spastic paraparesis or parasagittal meningioma. Or if there is sensory affection, I mean the case is mixed motor and sensory at the same time, then the differential diagnosis, and please pay attention for the next, we are having nearly 15 or 20 minutes and we'll finish. The mnemonic here is facts. These are the mnemonic for patients with paraplegia, yes, paraplegia with sensory affection. Facts. Please, doctor, pay attention because some of these things will not cause everything here. So please pay attention for the coming few moments. Now we are talking about patient. You examined your patient. You found your patient stiff, and the stiffness was bilaterally, and he had some sensory affection without level, but there is still sensory affection. So we'll ask about facts. What are the facts? Number 1, Friedreich ataxia. Number 2, amyotrophic lateral sclerosis. Number 3, conus medullaris syndrome. Number 4, cervical myelopathy. T, for tabes dorsalis. S for syringomyelia. And the last S for subacute combined degeneration of the cork. I will say some things now, doctor, and please write it down in your notes. I will not write them down. I will tell you what are them. So now, your patient, while you are examining his tone, you found him stiff, and the stiffness was bilateral. Now you are in the paraplegia level, and the paraplegia issue. So there is no sensory level, but there is sensory affection. So I will go here in the fact. So a case, upper motor neuron lesion plus sensory affection facts. Friedreich ataxia, amyotrophic lateral sclerosis, conus medullaris, cervical myelopathy, tabes dorsalis, syringomyelia, and subacute combined. These facts S3 or facts S2, they cause combined upper motor neuron lesion plus lower motor neuron lesion. This things, facts double S, causes upper and lower motor neuron lesion. Okay? But doctors, please, this disease, which is amyotrophic lateral sclerosis, no sensory affection. So why I put it here? I put it here because it causes also upper and lower motor neuron lesion. So please, this is an important point. I want you just only to notice it, because it will work with you during examination. So for example, if you found your patient is having bilateral upper, if he is having bilateral, yes, paraplegia, spastic paraplegia, and you found upper and lower motor neuron lesion, you will conclude amyotrophic lateral sclerosis. But if there is no sensory affection, you will exclude amyotrophic lateral sclerosis. But I just put it here because these cases are the same. These causes are the same. Upper motor neuron lesion, combined upper and lower, and also they cause sensory paraplegia with sensory affection. Okay. Then I want to say something also here about Friedreich ataxia. So I said, number one, amyotrophic lateral sclerosis, this is the first note, does not cause sensory affection. Come to Friedreich ataxia does not lead to lower motor neuron lesion. So why did I put it here? I put it here because during examination, Friedreich ataxia presents manifestations like this. How? Friedreich ataxia, doctors, I will write above here. Bismillah. Here. Friedreich's ataxia. What about unpaired anterior cerebral artery territory infarction? I have no idea, doctor. I have no idea. And doctor saying in amyotrophic lateral no sensory affection, doctor. Yes, no sensory affection in amyotrophic. That's but Doctor who said this? Doctor Salah. The things are clear now about amyotrophic lateral sclerosis or no? Now, do you know why I put it here? Dr. Salah, did you get the point why I put amyotrophic lateral sclerosis here? Okay, thank you. Because it will help you in the examination. So examining a patient, hypertonic or upper motor neuron lesion bilaterally showing upper and lower, you will include it here. I will come to multiple sclerosis, doctor. Give me time, I will tell you something. So, doctor, why did I put Friedreich ataxia here despite Friedreich's ataxia as an upper motor neuron lesion? See, doctor, Friedreich ataxia here, Friedreich ataxia is a combination of pyramidal plus posterior column plus cerebellum plus peripheral neuropathy. Okay? Pyramidal, posterior column, cerebellar, peripheral neuropathy. So pyramidal will show you upper motor neuron lesion in the form of usually hypertonia, hyperreflexia, upgoing blunt. Posterior column, sensory affection of joint position and joint movement and vibration. Then come to the cerebellum. The cerebellum, if there is cerebellar affection, the patient will not be able to do coordination. If he is having peripheral neuropathy, the tone will be affected. Sorry. The cerebellum, if he is having cerebellar affection, he will be having hypotonia. And peripheral neuropathy leads to hyperreflexia or hyporeflexia. Can you doctors write please on the chat box? Peripheral neuropathy leads to what? Hyperreflexia or hyporeflexia? Hypo. Very good. So now we are having a patient with pyramidal. I mean, look at the pen. The pointer. Pyramidal upper motor neuron lesion. Okay. Then cerebellum hypotonia and peripheral neuropathy hyporeflexia. You will think about upper motor neuron. You got my point? But in fact, it's not a lower motor neuron. The finding that you are having in Friedreich ataxia, it is not a lower motor neuron sign. The hypotonia you are seeing in Friedreich ataxia is secondary to cerebellar affection, and the hyporeflexia you are seeing is secondary to the peripheral neuropathy. He cannot do that. The tone is not good for this patient because of the cerebellum, and the reflexes are not good because of the peripheral neuropathy. So whenever you are examining your patient in case of Friedreich ataxia, you will find upper motor neuron lesion, and you will find lower motor neuron lesions apart from, sorry, you will find lower motor neuron lesion, hypotonia, hyporeflexia, upgoing blunter. Okay, did you get why I put Friedreich ataxia here in the causes of upper and lower? It does not cause lower motor neuron lesion, but it causes things similar to lower motor neuron lesion. Doctors, do you want me to repeat this part again? This is very important. Yes, doctor, it should be hypertonia. Okay, doctor, I will repeat it again. I will repeat it again. Don't worry. I will remove this. Again, no problem. See, if any person having cerebellar affection, he will have hypotonia. Okay? If he is having peripheral neuropathy, he will be having hyporeflexia. If he is having upper motor, by the way, this is lower motor neuron, yes, as we know. If he is having upper motor neuron lesion, he should have hypertonia and hyperreflexia. Okay? Patient with Friedreich ataxia is having upper motor and the cerebellum and peripheral neuropathy. So he should have hypertonia and hypotonia. And he should have hyperreflexia and the hyporeflexia. How does it come? It will not come. But you will see your patient exactly like this. He will be having upper motor neuron lesion in the form of upgoing plantar reflex. If this is the foot, okay, sorry, upgoing plantar reflex. Okay? And he will have hypotonia secondary to cerebellar affection. And he will have hyporeflexia secondary to peripheral neuropathy. Hypotonia and hyporeflexia are manifestations of what, doctors? Lower motor neuron. So what happens in Friedreich ataxia is not a lower motor neuron. It's something similar in the shape to lower motor neuron, but it is not a lower motor neuron. Did you get it now, doctors? Is it clear? So what will happen exactly? If this is the leg of the patient, sorry, I'm not good in drawing. If this is the leg of the patient with Friedreich ataxia, you will find lost knee jerk, lost ankle jerk, and upgoing plantar reflex. So what is this? You will think about causes of lower combined upper and lower motor neuron lesion. This is hypotonia, hyporeflexia, upgoing blunter. This is a combined. Then come to the fact is. These are the causes of facts S. So that I put all of them to each other. But now you know Friedreich ataxia does not lead to lower motor neuron. So the facts S will lead to this picture. Don't forget it. It will lead to hypotonia here, hypotonia here, hypotonia here, and hyporeflexia, and upgoing blunter here. Facts. But now you know that Friedreich ataxia does not lead to lower motor neuron. The hypotonia and the hyporeflexia that happens with Friedreich ataxia is secondary to the cerebellar affection and the peripheral neuropathy. Okay? And also we said that the amyotrophic lateral sclerosis does not lead to sensory affection. Okay, doctors? Everything is clear till now. Do you want me to repeat anything till this point? I hope everything is clear. Okay. Doctor, Friedreich ataxia causing lower motor neuron affecting as well. Clear. What I know, it can cause upper motor, but I don't know if it is causing lower motor neuron or no. Yes, it causes lower motor neuron in the form of peripheral neuropathy. But the presentation will be combined. I mean, doctor, again, I will tell you why I put fact S with each other. This is for clinical case. This is for clinical case. Now, you want to see a patient. You found your patient stiff, and finding him stiff, the stiffness was bilateral. Okay, and there is no sensory level, but there is sensory affection. There is sensory affection. Okay, then I will recall again what I did in the tone. I found that there is hypotonia, hyporeflexia, plus upgoing blunter. Hypotonia, hyporeflexia, and upgoing blunter, we are thinking about combined upper and lower motor neuron lesion. These are the causes. Okay, now if he is having cerebellar affection, so this is a Friedreich ataxia. Okay, the next is the multiple sclerosis. Multiple sclerosis leads to pure upper motor neuron lesion, purely motor, patchy. Okay, no sensory affection, no lower motor neuron manifestations. Okay, so it leads to purely motor. For sure, you can find cerebellar with this Friedreich ataxia, but as regard peripheral neuropathy, no peripheral neuropathy. Okay, but you can find posterior column affected, but for the peripheral neuropathies, no. So the last thing in this session, doctor, I know that you are now exhausted. The last thing, the cerebellar syndromes. If you found the patient is having cerebellar affection plus posterior column, I mean upper motor neuron lesion. Okay, so the next is to think about, is there any cerebellar affection? Sorry, I said cerebellar, I mean, sorry, this is pyramidal, I'm sorry. This is pyramidal. Okay, so the next to ask yourself, my patient is having cerebellar affection or no? If he is having cerebellar affection, he is one of two. Either Friedreich ataxia, if there is associated peripheral neuropathy, or it is multiple sclerosis if no peripheral neuropathy. Or if he is having pyramidal plus posterior column, but no cerebellar affection, no cerebellar. So my patient, one of two cases, either subacute combined degeneration if he is having peripheral neuropathy, or he is tabes dorsalis if no peripheral neuropathy. Okay, doctors. Till now, we are at the end of this session. If anyone want to ask our any question, we can help each other. It's okay, doctor. I will unmute you. want to unmute. Doctor, any doctor want to unmute himself or herself, he can.
Assalamu alaikum, sir.
Yeah.
Yeah, sir, I did not get the last part, the no cerebellar involvement. What is ahead of it?
So if the patient is having, if your patient is having upper motor neuron lesion, I mean pyramidal, plus posterior column affection, ask yourself, does my patient have cerebellar affection as well or no? If he is having cerebellar affection, so he is one of two things, either Friedreich ataxia or multiple sclerosis. The difference between Friedreich ataxia and the multiple sclerosis is the peripheral neuropathy. Peripheral neuropathy is present in Friedreich ataxia, not in multiple sclerosis. But if your patient does not have any cerebellar affection, so he is one of two, either subacute combined or tabes dorsales. The difference between them again, peripheral neuropathy is present in subacute combined, not present in tabes dorsales. Okay?
Okay, thank you.
Welcome. Any other questions, doctors? I hope everything is clear. Dr. Ahmad wants to ask something.
No, I want to thank you, doctor. Thank you very much. It's very interesting and very comprehensive.
Thank you, Dr. Ahmad. Jazakallah khair. Thank you. Okay, doctors. I will inshallah upload this one for the YouTube channel if you want to have a look at it again. Okay, doctors. Thank you very much. Jazakallah khair. Assalamu alaikum.